Welcome, and thank you for joining us today. My name is Ellen Wilson, and I'll be the moderator for this expert briefing for the media, which is hosted by the Johns Hopkins Malaria Research Institute. Today's experts will discuss the global state of malaria, including the latest research, the need for sustained investment, why malaria is so challenging to eliminate, and how modifying mosquitoes may be a way to combat the disease. I'd like to briefly introduce our speakers. Jane Carlton is director of the Johns Hopkins Malaria Research Institute at the Johns Hopkins Bloomberg School of Public Health, and a professor in the Department of Molecular Microbiology and Immunology at the school. George Dimopoulos is a professor in the Department of Molecular Microbiology and Immunology at the Johns Hopkins Bloomberg School of Public Health. We will have time for questions following our speakers' remarks. We will take some that have been submitted in advance of the briefing and some from the Zoom chat. If you have a question, please enter it in the Zoom chat addressed to panelists and hosts. Please enter your name, media outlet, and question. We hope to cover as many as possible. Please note that the participants are welcome to use images, video, or quotes directly from the briefing, and that the content is for immediate release. Participants will be muted during this briefing and it will be recorded. Let's go ahead and start. Professor Carlton, what is the current state of malaria?
Thank you, Ellen, and thank you to those of you who have joined us today to discuss the current status of malaria and the pivotal role that our institute is playing as we continue the fight against this global disease into the future. The latest figures from the World Health Organization estimated more than 260 million malaria cases and 600,000 deaths in 83 countries in 2023, an increase over the numbers for 2022. Tragically, 3/4 of these deaths occur in children under the age of 5, mostly in countries of sub-Saharan Africa. Fighting malaria is a complex global health challenge involving interactions between 3 dynamic organisms: humans, the malaria parasite, and the mosquitoes that transmit it. Global progress towards eliminating malaria has stalled in recent years and has faced unprecedented challenges, made even more acute during the COVID-19 pandemic, which diverted valuable resources. Drug resistance in the malaria parasite and insecticide resistance in mosquitoes threaten the strategies we use to control malaria. And mutated strains of the malaria parasite that are no longer detectable by rapid diagnostic tests are spreading. These challenges occur against the backdrop and uncertain impact of armed conflicts, ecological disasters, and climate change that have the potential to shift the geographic distribution and transmission patterns of malaria as we know it. Nevertheless, there is cause for some optimism. The World Health Organization has recommended the use of 2 groundbreaking malaria vaccines for the prevention of falciparum malaria, the most serious form of the disease, in children living in malarious countries. And new dual-ingredient insecticide-treated bed nets have also been recommended by the WHO that are expected to mitigate a common mode of insecticide resistance in mosquito populations in sub-Saharan Africa and elsewhere. And last year, the World Health Organization certified 5 countries malaria-free, including Egypt, a highly populous country in Africa, with several on track to eliminate the disease in the coming year. However, we need to continue building momentum towards a malaria-free future. World Malaria Day, held each year on April 25th, is a call for continued investment and sustained commitment to malaria prevention and control by the worldwide malaria community. Together, we are committed to combating malaria through cutting-edge research, collaborations with endemic country researchers, clinicians, and health workers, and leading science for a malaria-free world.
Thank you, Professor Carlton. Now a question for Professor Dimopoulos. What are the currently used strategies for malaria mosquito control, and why are they failing to eliminate malaria?
Thank you, Ellen. There are several methods to control malaria, but one of the most used methods is indoor insecticide spraying. However, widespread mosquito resistance to insecticides has become a major problem. It turns out that mosquitoes are very good at evolving and developing resistance to chemical insecticides, thereby making them ineffective for mosquito control. Mosquitoes have become resistant to multiple different types of chemical insecticides, and that also makes it difficult to find alternatives. The use of insecticides indoors has also made the mosquitoes evolve to bite people outdoors, again, making the indoor spraying ineffective. Another challenge in mosquito control is community engagement to promote consistent use of mosquito control and bed nets that are crucial but often difficult to achieve and maintain without community engagement and training program. It's important to remember that malaria is largely a disease of poverty, and it is disproportionately affecting poor and marginalized populations who often have poor housing infrastructure and limited access to mosquito control technologies. In general, I think we can say that the fight against malaria transmitting mosquitoes faces many complex and evolving challenges that include biological and environmental challenges, as well as operational challenges, along with the socio-economical. Given all these challenges, the Johns Hopkins Malaria Research Institute is engaged in developing several novel and impactful malaria control strategies. Thank you.
Thank you, Professor Dimopoulos. Now we will take additional questions. A reminder, if you have a question, please enter it in the Zoom chat with your name, media outlet question, and to whom you'd like to address your question. Let's take the first question from Francis Kokutz with SciDevNet for Professor Carlton. What is the current state of malaria across Africa? What is Africa not doing right? And what can be done?
Thank you, Ellen. Well, malaria is endemic in 47 of the 54 countries in Africa, and 2/3 of global malaria cases and deaths are concentrated in 11 African countries, including Tanzania, Uganda, and Democratic Republic of the Congo. However, 7 African countries have been certified malaria-free by the World Health Organization, most recently Cabo Verde, but also Morocco and Algeria. Malaria is very prevalent in developing countries, tropical and subtropical regions where resources are lacking and access to basic healthcare is limited, as Dr. Dimopoulos just told us. So it's not a question of what African countries are not doing right. It's a question of developing countries having limited resources to fight the disease and poor healthcare infrastructure. And the fact that the malaria parasite is a crafty species that mutates and evolves fast, developing resistance to almost every anti-malarial drug that we have developed against it. And it has a very complex life cycle as well. It's very difficult to detect and has complex biology that we as scientists are constantly surprised by. So what can be done? Well, World Malaria Day is a call to arms for the continued and sustained funding for malaria in 2 areas: funding for malaria control and elimination, and funding for malaria research and development.
Great. Here's a follow-up from Duncan Maboya, a freelance reporter. What is the state of malaria in Kenya and East Africa specifically?
The malaria situation in Kenya has declined, in fact, since about 2015, so over the past 10 years. And Kenya, along with Ghana and Malawi, received the RTSS vaccine some years ago now, and a study has shown a reduction in mortality and hospitalizations, so which is good news. There is a worrisome recent finding, however, that the invasive Anopheles stevensii mosquito appears to have migrated into Kenya, and so this could lead to an increase in urban malaria. However, expanding to other countries in Eastern Africa, such as Tanzania and Uganda, these 2 countries are in the list of 11 countries in Africa with the highest disease burden. So you can see that countries right next to each other can vary in the success of malaria control efforts, and this is often due to the availability of resources.
Great. And another related question, you did mention the vaccine. This is from Menda Litso Wills Kateta, asking how is the malaria vaccine helping to slow down the spread of the disease among under 5 children in sub-Saharan Africa?
So there are 2 malaria vaccines which are available now, RTSS and R21, which have been recommended by World Health Organization for use in malaria countries. And between 2019 and 2023, 2 million children in Ghana, Kenya, and Malawi received the RTSS vaccine. And an evaluation of the impact showed that there was a 13% reduction in mortality and a 22% reduction in hospitalizations of severe malaria, which is very good news. And in fact, by early December last year, a total of 17 countries in Africa had introduced the vaccine through routine childhood immunization. And there are many more who have signed up, many more have pledged to roll out the vaccination programs. So we are hopeful of a significant slowdown in malaria, especially if the vaccine is used in combination with other interventions, for example, seasonal malaria chemoprevention, which involves administering doses of drugs during peak season to children under 5. But of course, any of these interventions can be thrown off by ecological disasters or climate change, wars, etc.
Great, thank you. Here's a question for Professor Demopoulos. Your work explores how mosquitoes can be modified to prevent disease transmission. Can you discuss recent breakthroughs in mosquito vector control and the challenges in implementing these approaches at scale?
Thank you, Ellen. Yeah, one very interesting new approach under development is the genetically modified mosquitoes. Since mosquitoes are responsible for malaria transmission, many researchers have focused their attention on curing mosquitoes from malaria by developing genetically modified mosquitoes that are resistant to the malaria parasite. And we have shown that this is possible. The Johns Hopkins Malaria Research Institute has, for example, developed several different genetically modified mosquito strains that are resistant to malaria. A challenge, however, is how to spread these mosquitoes or the malaria-resistant genes in nature, in natural mosquito populations. And a relative new technology that can overcome this obstacle and spread malaria-resistant genes in mosquito populations is a so-called gene drive. The idea is that we can use this technology to convert an entire mosquito population to become incapable of transmitting malaria by only releasing a relatively small number of these gene-drive mosquitoes. The key advantage of the technology is that it won't require much compliance or participation by the endemic population, since these mosquitoes will spread on their own. The approach is also egalitarian, as everyone will be protected. It could also possibly represent a low-cost and sustainable malaria control approach. Many challenges remain, however, to deploy this method. For example, we need to make sure that these mosquitoes are sufficiently fit and also resistant to multiple malaria parasite species and strains, and that the parasite won't develop resistance to these genetic blocking mechanisms. There are also challenges with acceptance of these technologies since they are so new and haven't been tested yet in nature. So a variety of activities and studies are currently conducted to address these challenges by laboratory assays, stakeholder engagement, and community engagement programs. Thank you.
Thank you so much. A question from Apollonia Adeyemi with New Telegraph for Professor Carlton. Why is eradicating malaria so difficult, particularly in an endemic country like Nigeria? Any hope of achieving malaria elimination in malaria endemic countries?
Well, it's good to remember that there's a difference between eradicating a disease, which is permanently removing it globally so that no further interventions are required, a good example being smallpox, and elimination, which is stopping the transmission of the disease in a specific geographic area. And malaria elimination is possible and has occurred in 44 countries, which are now malaria-free, and 5 countries just this past year, Belize, Egypt, Azerbaijan, Tajikistan, Cabo Verde. Nigeria has the largest population of any African country, but the vaccine was introduced last year into the country. And many of us in the malaria community have hopes of achieving elimination in more countries over the coming years.
Great, thank you. A follow-up for you, Professor Dimopoulos. How concerned are you about the emergence and spread of Artemisinin-resistant malaria in Africa?
I think this is probably a question for Dr. Carlton as it relates to drug resistance of malaria parasites.
Great, and that was from Chris Dahl with CIDRAP News, by the way. Go ahead, Professor Carlton.
Yes, indeed. There have been reports of artemisinin-resistant parasites in African countries, most recently in Uganda, and this is concerning. There is some good news. For example, similar resistance has not impacted other countries such as India, but in Africa, this is a particular concern. Now, there are many surveillance studies being undertaken in several countries, Rwanda, Kenya, Zambia, and Ethiopia, as well as Uganda, to keep an eye on the spread of this particular resistance. But the journalist is absolutely right. It is concerning.
Great, thank you. And here is a question from freelance journalist Caitlin Sullivan for you, Professor Carlton. Is there any push to manufacture malaria medications, vaccines on the African continent? And if so, what is the impact that might have, especially given the recent aid cuts?
Yes, indeed. The World Health Organization has established the Accelerating Malaria Vaccine Introduction and Rollout in Africa, AMVERA initiative. And this is specifically designed to support countries in introducing and scaling up malaria vaccines. And its efforts to establish local manufacturing capabilities include partnerships for African vaccine manufacturing, and they aim to achieve 60% local production by 2040. There's also a push to strengthen local manufacturing of anti-malarial drugs, and in particular, the African CDC and Medicines for Malaria Venture are very involved in that. And in fact, in 2022, one company in Kenya became the first African-based manufacturer to receive WHO pre-qualification for a malaria drug. And there is a second Nigerian manufacturer that is about to receive pre-qualification as well.
Great, thank you. A question for you, Professor Dimopoulos. You've touched on this, but James Deneen at New Scientist is asking, what is the state of research on gene drives to control malaria vectors? If there's anything else you can say on that topic.
Yes, absolutely. Thank you, Ellen. So gene drive technology based on the CRISPR-Cas9 system that can spread mosquito genes in natural populations has advanced very significantly in mosquitoes over the past roughly 10 years and have now reached a state where they are efficient and stable enough to be able to spread their cargo genes that makes mosquitoes resistant to the parasite in large cage populations. Of course, studies remain to assess their efficacy in open field trials. These gene drive technologies can be used to either make entire mosquito populations resistant to the parasite or to suppress mosquito populations. Significant research is now focused on developing safer drive systems, for example, gene drives that are geographically limited or self-limiting over time, as well as robust methods are being developed for monitoring and potentially even reversing gene drives if needed. So this is an ongoing research, and we see advances evolving every month. Thank you.
Great, thank you. Here's a question from Alik Ponche with the Times Group in Malawi for Professor Carlton. Malaria has received a lot of assistance in the fight against malaria, but the disease remains a big health threat in many districts. Are all the prevention methods not working because of failure to correctly use them? What should really happen to eradicate the disease? There is the fear that with the current geopolitical issues regarding aid, the gains might be reversed. How do we leverage local resources in the fight against malaria?
Thank you. So it's not a matter of incorrectly using the interventions that we have. It's actually more the availability of them. As we stated previously, malaria is really found in areas of the world where there is poor health infrastructure, where resources are scarce. And those resources can include the control methods that we would use, for example, controlling mosquitoes, the way that Dr. Manopoulos has mentioned, but then also the access to rapid diagnostic tests and to drugs as well. So it's not so much incorrect use of those, it is just more availability. And can you remind me the second part of the question?
Yes, how do we leverage local resources in the fight against malaria?
Oh, well, this has happened for time immemorial. I would say local resources include the local scientists who are researching better methods to control and treat the parasite. There are a number of research organizations in African countries who are all working towards this. And even in universities as well, studies are ongoing, perhaps to use some local plants as anti-larval type chemistries. So a lot of that already goes on.
Great, thank you. Now we're turning to a different region of the world. A question from Bindu Jajan with the Hindu for Professor Carlton. How is India doing in terms of malaria control?
India, the burden of malaria in India has reduced dramatically. There's been about a 70% reduction in cases from just over 6 million in 2017 to 2 million in 2023. But 2 million cases is still quite a large number, and that's because India has the largest population of any country in the world at 1.2 billion. But this is still a phenomenal achievement. Perhaps luck has been a little bit on their side. As I mentioned, there's been no sweep of resistance against the Artemisinin combination therapies, which have been introduced into the country. But also there have been very good use of innovative control measures, such as the Daman malaria camps in hard-to-reach tribal areas of Odisha, which have a good success story. India also has a long history of supporting its malaria control and elimination efforts and its malaria research and development through, for example, the Indian Council of Medical Research Institutes, such as the National Institute for Malaria Research. And so India may well be in reach of malaria elimination by 2030, as it has been working towards.
Great, thank you. A question for you, Professor Dimopoulos. Your team's recent study explores a fascinating approach targeting a mosquito's own molecular quality control system to both disrupt malaria transmission and reduce mosquito survival. How could this be a game-changing target for future malaria control strategies?
Thank you, Ellen. Yes, indeed. One of our recent discoveries could become a very effective weapon against malaria, since it can target all malaria parasite species and strains, and it can also work in all malaria vector species. So in this way, it becomes a malaria control strategy that could work in all malaria endemic areas. We have shown through our research that the health of the mosquito gut depends on a protein quality control system called the profolding complex. And when we disrupt this control system, the mosquito's gut loses its integrity. The mosquitoes become very sick, and a large proportion of them will actually die. And if they're infected with the malaria parasite, it will block the parasite. So this strategy targets both the parasite and the mosquito simultaneously. And our current studies are now looking at ways on how we can translate this discovery into a technology that can be applied for malaria control. We are looking at different ways by which we could disrupt this mosquito gut system in nature. Thank you.
Thank you so much. A question for Professor Carlton. Climate change is expanding the geographic range of malaria. How are researchers adapting malaria surveillance and control strategies to address this shifting threat?
Yes, that's a very interesting question. In fact, it goes against intuition in a way, but increasing the temperature doesn't always increase the number of malaria cases. The malaria parasite can only infect a mosquito within quite a tight temperature range. And if it gets too hot, the mosquito will not be able to develop in the mosquito. So that's an interesting kind of nut to throw into the equation. But indeed, the spread of mosquitoes, the range does seem to be shifting as areas get wetter due to climate change and other areas become warmer as well. So there is an increasing shift and an increasing understanding that surveillance of this particular issue is important. One of the ways that scientists have been doing this in particular has been looking at the invasive Anopheles stevensii mosquito. And this is a mosquito species which is quite common in India, for example, and also parts of Asia, Southeast Asia. But it has invaded into the Horn of Africa, and that is causing concern. So indeed, there is increased surveillance of this particular species and also of other areas where malaria now may be a problem.
Great, thank you. For you also, Professor Carlton, a question from freelance journalist Esther Nakasi. Malaria funding is one disease that will be impacted by the aid cuts of the current U.S. administration. What are the estimated losses we will see in the near future?
Yes, indeed. This is problematic. So reduction in aid to support malaria control and surveillance is extremely concerning, and especially through the termination of organizations such as the President's Malaria Initiative and other USAID initiatives. Many of our research collaborators in the countries where we work, such as Ethiopia and Zambia, have told us that supply chains for malaria tests and drugs have been disrupted and dispatch of mosquito nets has stopped, severely disrupting activities of national malaria control programs. In fact, there's been an analysis from the Oxford Malaria Atlas Project, or MAP, which tracks global burden of malaria through data collection and analytics. And they have projected that with a freeze for 1 year of PMI activities, this would result in up to 18 million additional malaria cases and up to 107,000 additional malaria deaths. And this represents an increase in morbidity of 13% and mortality of 40%. And this would be in PMI's focus geographies across 27 African countries. And in fact, this analysis doesn't account for the additional impact of PMI-supported diagnostics or preventive treatment for pregnant women, which would further add to the averted burden. So in fact, this paints quite a bleak picture.
Thank you, Professor. Building on that, as the final question, what policy or funding commitments are most urgently needed to accelerate progress toward malaria elimination?
Yes, indeed. Globally, total investments in malaria control reached an estimated 4 billion in 2023, but this already fell short of the 8 billion funding target of the World Health Organization Global Malaria Strategy. And so the funding gap has in fact widened over the past 5 years and increased from about 2.6 billion 5 years ago to the current 4.3 billion in 2023. So we really need a renewed commitment to reach these targets in the coming years. We need renewed commitments from governments worldwide to provide funding for malaria control and surveillance and malaria research and development.
Thank you to Professors Carlton and Demopoulos for your insightful answers. We will email the links to the resources mentioned today and shared in the chat. If your question was not answered today, please contact Katie Leonard, kleonard@burness.com, to arrange an interview with the experts. With that, I'd like to say thank you again to everyone for joining us today.